Okay, thank you. And we proceed now with the symposium of TEVA. Thank you. TEVA is supporting BEC meetings since more than 10 years, so I'm so thankful, grateful. Thank you so much, really. Guys from TEVA, thank you for your support. Without the support of the companies, of the pharma, it's not possible. And because of that, by the way, because of that, the participation fee is so low. You know, in case you're going to go to TCT or the PCR, you are going to pay between $900 and $1,000 or euro. So thanks to the help of the industry, we can, in our Balkan region, we can afford to have low participation fee. Okay, speaking about, it's a little more cardiology topic, but cardiology, angiology, vascular surgery, all we are in the same carriage. So we are treating the same patients. You know very well that coronary and peripheral arterial disease, there is a huge overlapping, about 40%. So for example, my scientific thesis, one of them is for carotid intervention, and in my cohort of patients, 65% of the atherosclerotic carotid disease patients, 65% have coronary artery disease, and about 40% of the peripheral artery disease patients, they have also coronary artery disease. Probably I will ask a question. We have several colleagues from Serbia and Macedonia. Hopefully you will understand me if I speak Bulgarian slowly. I'm not a slow speaker, but I will try to speak slowly. Somebody else? Only English-speaking person? Okay. Okay. I will tell you after that resume, overview in English. So, in fact, okay, platelet function is very, very important. Platelet function is very important for protection of thrombotic and also ischemic events, because these patients, they share in most of the cases big ischemic and big hemorrhagic risk. And the platelet function is crucial, is very crucial to decide what to do with the therapy, and to emphasize on bleeding risk protection or the ischemic risk prevention. Okay, we are in fact, we have to have in mind that adherence to evidence-based practice guidelines is very important. Not because the guidelines are already always the right strategy, but because they are protecting us. And in fact, it's very important to have a notion. I'm speaking about the acute coronary syndrome, not stable, acute coronary syndrome. And we have several goals: to have optimal outcomes, to have symptom improvement, reducing angina, of course, in the future, enhance the patient outcomes. And the vulnerable plaque also have to be passivated, because inflammation, that is the main trigger. It's clear during the last several years, it's absolutely true, absolutely clear that the inflammation is the leading cause not only for the plaque formation, but also for the plaque destabilization. And since Rudolf Virchow 130 years ago, with the first microscopes, he has shown us that the inflammation is preceding the plaque formation. So the cholesterol, the LDL cholesterol, need first to form the foam cells, inflammation, and secondary, to destabilize the plaque core, also we need to have presence of inflammation. And on such a way, it's quite difficult to weigh the ischemic or the bleeding risk. You see, it's very difficult. In fact, during the acute period, the ischemic risk is higher. But in order to correct the ischemic risk, sometimes we are emphasizing too much on antiplatelets, anticoagulants, and so on, and we are instantly increasing the bleeding risk. And in many cases, we have to weigh the pro-ischemic or the pro-bleeding factors are important for a particular patient. This is the so-called tailored or individualized approach. So you see below, these are the factors that are increasing the risk, and above, they are the factors that are decreasing the risk of thrombosis. And obviously, for a particular patient with acute coronary syndrome, that is a thrombotic event, for the first our thought is to prevent the thrombotic event. So what we can do optimal stent implantation. We can do optimization of the stent after the implantation with the high non-compliant pressure balloon inflation. We can apply COX-1 inhibition, aspirin of course, and not all. And we have to combine the aspirin practically in 100% of the patients with acute coronary syndrome, P2Y12, prasugrel or ticagrelor. Both of them are very good. Both of them are very good with some details in some clinical situations. You are going to see what I mean. And inhibition of thrombin generation action, oral and platelet anticoagulants, sometimes, mainly in the patients with atrial fibrillation. So this is the triple therapy. And during the time, this is the picture of the how we decide what is the risk of stent thrombosis. It depends on the complexity of the lesion and the complexity of the stent procedure and the complexity of the stent strategy. For example, two-stent, Y-stent, kissing stents, all these strategy that are adding second stent, not only one stent strategy, is increasing the risk because they are leaving more metal, more material on the carina. So bifurcations, long lesions, calcific lesions, under expansion of the stent, tortuosity of the segment, complex procedure, long procedure, contrast material utilization. You know that all the medical continuum, the kidney function is crucial for the prognosis. And the contrast-induced nephropathy is one of the biggest enemy of good result. Unfortunately, the complex coronary procedure is related to contrast utilization. And we have to have in mind all these features. And in case we have 6 centimeters of stent implanted, obviously we cannot leave these patients without anti-aggregation, without antiplatelets. And in order to be even more complex, in diabetics, it's even more difficult because diabetics are prone not only to thrombotic events, they are much prone for restenosis. And because of that, we have to have in mind what to do. I mentioned already the potent P2Y12 inhibitors. Among them, ticagrelor and prasugrel are the most important and the most advanced that we have. And the other thing, it's very important, since the European initiative Stand for Life, we know how important is the time. So the time is saving lives. So it's, you see how the risk is increasing. After 90 minutes of waiting or losing time, the risk of the patients and also the thrombotic probability during the procedure and after the procedure is increased dramatically. Okay, so we have to take a look not only on the coronary angiogram, but also to stability of the patient, stability of the other part of the circulation, or instability of the other part of the coronary arteries, because we have, for example, very nice Spanish trial have shown by IVUS, have shown that beyond the culprit lesion, we have at least 50% of the other plaques, even not severe stenosis, they are prone for destabilization and thrombosis. And because of that, during the timeline of acute coronary syndrome, we have to have in mind also the situation, the anatomical situation of the other part of the coronary tree. Пробвайте да мръднете слайда, че аз не успявам. Напред просто. And definitely the hemodynamic stabilization is very important for these patients, because the hemodynamic instability is one of the predictors for bleeding, and it's very important. And in case they succeed to move the slide, you are going to see that during the timeline of the acute coronary syndrome, in the acute and subacute phase, we weigh more the ischemic risk, and after that is the predominance in the clinical decision is the bleeding risk. And because of that, late in the late phase, we have to have a risk assessment and to have the risk scores, bleeding risk scores, and the precise DAPT is one of the best scores that is telling us what to do, how long has to be the antiplatelet. You know that in the guidelines, next please, in the guidelines, in the present guidelines, we have preventive strategies that are related to at least double antiplatelets for a longer period of time, and even more. In some clinical situations, next please, in some clinical situations we have to utilize the double antiplatelet therapy even more than 12 months. The so-called BRTP score is also very important. It's not very often used, but this is BRTP score is based on the laboratory result showing us the hemoglobin, the situation with the platelets, the volume of the red blood cells, the volume of the platelets, the formulation and the shape of the red blood cells and the platelets. So all this is gathering points next, and added to the syntax score, the BRTP score will tell us what is the probability of a particular patient to die in next several months or next several years. Next. And it's because of that syntax 2 and BRTP and precise DAP scores are very important in our decision making, and definitely bleeding thrombotic risk balance is the crucial one. And this tailored risk stratification that I mentioned already several times, it's really definitely very important. And in the context of the timeline, you see this is in fact the acute phase, the subacute phase, and the late phase, the proportion during the first year, all these bleeding and ischemic events. What I was mentioned already, you see that during the timeline of a particular patient, in the beginning, the acute and subacute period, there is a ischemic risk, and after that we pay attention more to the bleeding exceed risk to decide what to do. In fact, one of the most important strategies is related to the potent P2Y12 antiplatelets. Of course, clopidogrel is important, no doubt, but in the context of acute coronary syndrome, the ticagrelor would be the medication of choice in many of the patients. There are several particular ones. I mentioned already that time is life. So in case we have some delay, it's more logic to load the patients with ticagrelor because it's faster compared to prasugrel and aspirin definitely. And the other clinical scenario is our hesitation. Is the patient intended probably for CABG or not? Is it a multiple vessel disease and he probably has to be operated in a short period of time? In this situation also ticagrelor is the preferred one because the on effect is faster, but also the off effect is faster. So after interrupting the ticagrelor utilization, recently he can be operated without severe bleeding risk. And definitely Teva, they have already the ticagrelor Teva on the market, and this is a very important message for us, the clinical specialists, because it's recommended in the majority of the acute coronary syndromes, of course, together with the prasugrel in other indications that you know very well. And thank you very much for your kind attention. questions?
About the situation after the COVID, maybe, I don't know, I think it's the same in Bulgaria and Serbia. We have noticed that a lot of our patients, we don't have now focal plaques. We have long lesion coronary disease. So the patient that we treated with the long stents.
Absolutely.
And this is maybe the ticagrelor is the best choice, even although sometimes we go with 2.5 rivaroxaban, maybe for long lesion, long stents, and this is the perfect situation that we have as help from the pharmaceutical companies.
Absolutely, you're absolutely right. This is reminding me that, in fact, the guidelines definitely is favorizing the direct oral anticoagulant, not the vitamin K antagonist anymore since a long time, but now we have data and we have the guideline. And in case we have to combine anticoagulation with 2p-Y12 inhibitor, it's a direct oral anticoagulant together. And rivaroxaban after the COMPASS trial was is probably one of the good choices to combine, definitely.
One question,
Yes.
how you see antiplatelet therapy in future time? When you change dual antiplatelet therapy with single antiplatelet therapy for all patients, acute and elderly patients? Now we have more potent
it's
drugs.
quite difficult to say, but still, you know, in the guidelines, we have at least several weeks for a relatively short period of time, at least double antiplatelet. But to be fair, I was thinking about this question during our participation in Onyx 1 trial. I remember that we received an amendment, correction of the protocol in which they allowed us in patients with high bleeding risk to start immediately, even during the procedure and the hospital stay, with single antiplatelet. So there is some move toward this strategy, probably because the stents are becoming better and better, and the probability, and in case after good vessel preparation, atherectomy devices, a good final result, no problem with the T3 flow. In all these situations, especially in stable coronary syndrome, we are extremely conservative and very liberal to give single antiplatelet. So we stay for a very short period of time, 2 weeks, 3 weeks, no more, and after that we are removing. In most of the cases, we are removing the aspirin. Also, the guidelines is favorizing the P2Y12 stain on the treatment because the aspirin is acid and the gastrointestinal bleeding is higher.
We have new American guidelines. In these guidelines, we can stop aspirin 1 month after acute phase.
Absolutely, yeah. You're right. Okay, probably Professor Stankov will